Should I stop screen share for a few minutes, 1 or 2 minutes?
Okay,
After that,
sure.
you can start.
Okay.
So, dear doctors, attention, we are starting the session for today. Good afternoon and welcome to one and all. I'm Ritparna from Clarinet, the designated session assistant for a seamless experience, and Clarinet is India's most trusted and widely used digital platform with multiple enriching services exclusively for the doctors. Clarinet is very proud to be a digital partner for this new Natal Pathshala PT seminar on medication errors in newborns, organized by the National Neonatology Forum, Gujarat State Chapter. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Prashant Karia, the Honorable Secretary of NNF Gujarat. Over to you, sir, to share a few words.
Thank you so much. On behalf of NNF Gujarat, in Neonatal Pathshala, I, Dr. Prashant Karia, the Secretary of NNF Gujarat, welcome one and all. Neonatal Pathshala we are doing since last 1.5 years, and today we are lucky to have an international faculty with us. Sir is kind enough that on morning 5 a.m. he has joined to our Neonatal Pathshala. So I request our President, Dr. Dipen Patel, to introduce today's experts to us. Thank you.
Thank you, Dr. Prasant Bhai. Today is really a beautiful day for us because we have Dr. Suresh Gautam sir, whose vast experience in this program will help us and our students to learn and achieve the goals and improve the outcome in newborns. I would like to introduce our faculties and welcome you all on behalf of Gujarat NNF. I, Dr. Dipen Patel. I would like to thank Dr. Professor K. Suresh Gautam, who is from USA at 5 o'clock, is here with us to help our students learn more. He has a vast experience to his name. He has several degrees. He is currently a section head and service chief and attending neurologist at Texas. Yes, sir.
Sir is at Florida now. He has moved. He's not at Baylor and in Texas.
Okay.
Florida.
Right. So this is an error, sir.
It's okay. You can keep it short, the introduction.
Yes, sir. So sir has been a professor at Baylor College of Medicine. Sir is an associate editor at the Neonatal Review Group of Cochrane Collaboration. He has served as a faculty at Vermont Expert and Dartmouth Institute, Giesel School of Medicine. He is a chair at American Academy of Pediatrics and Education in Quality Improvement for Pediatric Practice. Sir has set up and directed several education courses. His area of interest are patient safety, healthcare quality improvement, evidence-based decision-making, translation of research into practice, ethics, humanism in medicine, and organizational culture and leadership in healthcare. Sir is author in several peer-reviewed scientific publications, presentations, book chapters, including Cochrane systematic reviews. We welcome you, sir, at Neonatal Pathshala.
Sir has finished his MBBS from Karnataka and I think MD and DM from PGI Chandigarh.
Correct. Yeah.
So we have an expert, Dr. Professor Somsekhar Nimbalkar, who is our guru and mentor. He has also several degrees to his name. Currently, he is professor.
You can skip this. I think this is enough.
Okay, sir. He is a professor and head of pediatrics at Karamsad. He is editor-in-chief of Journal of Neonatology, and he has several achievements and awards to his name. We have with us Dr. Kedar Savleswarkar, who is a director and chief neonatologist at Devgiri Children's Hospital, Aurangabad, Maharashtra. He was the formerly associate professor at GMC Aurangabad. He is associate editor of BMG Open Quality South Asia Edition. He is national faculty in several programs, and he is a founding member and national mentor at Nationwide Quality of Care Network. He has also received MS Signature Awardee year 2022. We welcome Dr. Kedar in this session as an expert. We have Dr. Shraddha Patel, who is going to present this talk on medication errors in newborn. She is currently doing IIP fellowship in neonatology at Pramukh Swami Medical College, Baikaka University, Karamsad. She has also done fellowship in pediatric critical care at Bhai Zerbai Wadia Hospital for Children in Mumbai. I request Dr. Somsekhar Nimbalkar to take over the session and guide Dr. Shraddha for her presentation. Thank you, everyone.
Thank you, Dr. Dipen, for the introductions. And I think we can all start the presentations. I request everyone else except the experts and the presenter to switch off their videos. And Dr. Shraddha, you can start off by your presentation. And anyone who has a question can definitely
Yes, sir.
message me. And if you want to message me on my WhatsApp also, that is also fine. Please go ahead. Thank you. Make it full screen, Shraddha.
Yes, sir. Okay. Is it okay now?
Yeah, perfect. Go ahead.
Okay. So, good afternoon, everyone. Today we will be discussing about medication errors and particularly medication errors that happen in the neonatal ICU. So we are discussing because they are by far the most common forms of medication errors, and it is considered that more people in the US die as a result of medical errors than from other causes, important causes like motor vehicle accidents, breast cancers, or AIDS. One of the study we have of PICU reported that 68.5% of all errors were medication errors, and it is said that the risk in NICU is 10 to 100 folds than that in the pediatric or adult patients. So, but the only concern is that the number reported in all the studies and that we have can be misleading, because a very small percent of errors and adverse drug reactions are detected, and even further small numbers are reported. And there are a lot of inconsistencies in the ways the errors would be reported and counted. The another topic is majority of the studies have included patients who are in patient settings, and OPD basis error in case of drug omission or improper prescription or some drug errors are not even considered. Majority of the studies focus on error of commission. Error of commission is like wrong drug, wrong patient, wrong dose, something like that, and failure, and they do not consider failure of omission. So failure of omission as in the drug is not even prescribed or not transcribed by the pharmacist and so on. And the most important which we can consider is the culture of safety. So in case any drug even happens, the staff is not really safe to report it because of the fear of a blame or a culture in which they feel very insecure to talk about the error. So this reported epidemiology of this iatrogenic disease, which is related to medication error, is just the tip of the iceberg that we are able to see. So basically in this presentation, we'll just go through the definition of medical errors and would classify various errors and the extent to which they occur, and the impact on patient factors, in multiple causes that lead to the errors, and how to report and eventually minimize the overall errors. So based on the National Coordinating Council for Medication Errors and Reporting and Prevention, it is defined as any preventable event that may cause or lead to inappropriate medication use or patient harm, while the medication is in control of the healthcare profession, patient, or the consumer. It is also said that it is a failure in the treatment process that leads to or has the potential to lead to harm to the patient. And this form of error can occur from any time, from the phase of prescription to in the end till the consumption by the patient. So we'll also discuss the stages of the medication process, which starts from prescribing. So prescribing is mainly done by a healthcare professional or a doctor who will assess the patient, who would assess the need for a particular medicine for that condition. He will evaluate the condition and decide upon giving a particular drug. This is in form documented in the form of a prescription, which is known as transcribing, and this prescription reaches the pharmacist where the drug is dispensed and further reaches back to the center where the nursing would administer the drug, and the most important part would be monitoring once the drug is given. So these events or whatever medication errors happen can be due to, in the case of settings like professional practices, healthcare products, professional symptoms, prescribing errors, or order communication, issue in the product labeling, compounding, distribution, and various other stages. So why are we discussing medication errors? The most important is patient safety. So any error that occurs in a patient that can have severe consequences on the patient, like maybe an adverse drug reaction, a treatment failure, or a prolonged stay of the patient in the hospital, or even death. So that is why it is very important to discuss and improvise on this. It is also a very important preventable cause. So basically, through developing proper system, fixed protocols, and proper educational systems, we can always try to minimize the errors as much as possible. And this will in fact determine the overall healthcare system improvement. Learning and improvement is also important because openly discussing medication errors allows for a culture of learning from a mistake, sharing experiences, analyzing errors, and going to the root cause of any error that can occur. This also develops strategies for prevention. Healthcare providers can also involve in patient engagement, where the drug is explained to the patient. In case of newborns, the patient's relatives, the risk factors, the complications can be also explained to the patient's relatives. Healthcare providers can also adhere to the transparency and accountability principles. And this also helps in research and innovation. So various newer technologies and protocols can be innovated, which would further help in minimizing the errors. And overall, discussing these errors would create a proactive approach towards patient safety and foster a culture of continuous improvement and drives positive change within healthcare systems. So in case of newborn, in case there is any error that has occurred, that would eventually lead to increase in mortality, morbidity, and long-term effects on their growth development and overall health outcome, and eventually emotional and psychological impact on both the parents and the healthcare providers that are involved. Now, particularly in newborns, why there are increased risk of the medication errors, there are certain points that we can discuss. First is the dosing error, because the newborns doses, there are various calculations required based on the weight, based on the gestational age, based on the various change in the physiological factors. In case of preterms, there are different physiological factors involved. There are different metabolism and excretion of different drugs that are involved. So based on all these, very precise calculation of the doses with proper explanation is required. Medication selection errors can be there because the adult formulations are available. In different formulations, they need to be diluted and very minimal doses need to be given, or even the concentration that the drugs are diluted with proper duration, the drugs need to be given. Sometimes a wrong route or an improper technique also can lead to ineffective drug to the patient. Like one example, for a wrong route, we can consider that by mistake a drug is delivered through an umbilical arterial catheter instead of an umbilical venous catheter, just because of a wrong labeling or just by mistake. So that can happen. Or maybe a drug is which has to be given over a period of 30 minutes is given very fast in maybe 5 minutes. That can also affect the patient. There are a few drug interactions, potential ones. So there is a list of high-risk drugs, and always the drug interactions need to be considered when giving multiple drugs together. Communication errors are also the important ones, because if there is no proper documentation, illegible handwriting, or lack of clarity in prescribing, all these can lead to medication errors. There are also chances of a wrong patient error that can happen, especially in naming conventions that are commonly used in our NICU, like baby boy, baby girl, or male child of this patient, female child of this patient. So what this would lead to confusion in the patient, particularly more likely in twins or higher order of pregnancies. Polypharmacy, like newborns, require multiple medications to manage their conditions. So there is too much complexity in the regimens. Maybe some drug would be missed, or maybe there is some drug interaction that can happen. So this is just one prescription in our NICU having these multiple drugs. Like in this prescription, if we take it positively, the drugs are written in capital letters. Most of the drugs are written in capital letters. High-risk drugs like adrenaline and noradrenaline have a red underline that is mentioned. But if we see the dosing form and the dilutions at multiple places, we're able to see that the microgram looks like an mg. So this is again a proper documentation error. Then here the microgram looks like an mg. Proper route is not mentioned, whether it has to be given in IV or a sub-Q form. And one important thing that we have to note into prescription is that in case of any correction, there has to be a single stroke, or maybe it has to be written over again in the next step rather than scratching it in such a manner. So we'll again discuss the possible causes of medication error. This is a Fishman diagram which determines the causal effect relationship between for the medication errors. So one section is the people. So this errors due to people can happen due to maybe a casual attitude, or maybe a wrong intent, or maybe untrained staff. Sometimes we have a very junior or a new nurse coming in the ICU who would not know certain drug formulations, or maybe certain ways a drug has to be diluted, or an inexperienced new staff, or emotionally unfit person maybe, and wrong dispensing by the pharmacist, illegible handwriting of the doctors, which we just discussed, or maybe a shift change time in a hurry. This happens many a times that when a drug is or something, some prescription has been given between two shifts, there is high chances that it might get missed. That one shift they would want to give it in the next shift, and then there is some confusion that can happen. Environment issues like pharmacy manpower constraint for dispensing, which would lead to overall dispensing errors. Maybe pharmacy has a poor drug storage, poor ventilation, lighting, humidity, which are the overall factors that can affect, or maybe pharmacy space constraint for dispensing. In case of equipment, a defective syringe pump can also lead to a wrong delivery of the dosage. And in case of the process, maybe wrong stocking of the drug, expiry dates not checked, near expiry drugs have to be considered, proper temperature required for the drug storage, wrong labeling, look alike, sound alike medication error, stockouts, no cross checking, and maybe improper diluent or unauthorized replacement of the drugs. So all these factors given together can lead to medication error. So some of the corrective actions which can be done can include training, manpower recruitment, pharmacy stock rectification, equipment replacement, or rectification. So based on these errors, there are a few categories of the harms that are mentioned. Basically, there are 4 harms: no error, error and no harm, error and some harm, and error that leads to death. So first is no harm or no error, category A, where there could be circumstances or events that have the capacity to cause error. Maybe a not proper functioning work environment, or a not proper handwriting, which has the capacity to cause error. Now in category B means that some error occurred but did not harm the patient much. For example, some multivitamin, some vitamin D drug is missed, but it has not reached the patient, but it is not going to grossly affect the patient. Category C and D are just like minimum errors affect, and they are causing very minimal patient harm, or maybe monitoring is required to confirm the harm. Now these are the severe ones, category E, F, G, H, where there would be an error which would lead to maybe a temporary harm or a significant permanent harm. Like we can consider like some nephrotoxic drug has been given, and it has been given in maybe a 10 to 100 times higher dose because of some calculation mistake. So this will cause acute renal injury and would require intervention and prolonged hospitalization. Another example is some high risk drug like potassium chloride given in a very high drug dosage. So we have to give we have to either give calcium, or maybe if it is given in such a high dose leading to arrhythmias or death of the patient. So based on these categories, we can also report the patient, which we'll be discussing later on. This slide is just wanting to show the working definition of medication errors, which are adopted from the American Society of Hospital Pharmacists. And this is just a table which shows the high risk medications. Probably most of the ones used in NICU would be adrenaline, noradrenaline, dopa, dopamine, ketamine, or in case of sedation, fentanyl, and milrinone, vasopressin, and so on. So this is a very interesting model. This is known as the Swiss cheese model. Like we've already discussed the causal relationships or the causes of the medication errors. So here the 4 physical barriers are the 4 successively placed barriers. The first one is the prescriber. The second one would be the pharmacist, then would be the nurse, and the last would be the patient. So these are the 4 physical barriers, and the smaller holes the thinner holes that are there in the cheese, which are not uniformly organized, are the latent errors that can happen to eventually lead to patient harm. So any missed error at one point can successively cause error at various levels to reach the patient. Sometimes the best example about this is the best barrier can be nurses can be the best barriers in certain cases. We would have had instances where maybe the prescription is written wrong by some, especially in a teaching hospital, maybe by some resident. So the nurses who are there from a very long time would identify that error, and they would make sure that they would cross check it with some other senior, and they would identify a lot of errors, and thus helping in avoiding errors most of the times. The role of different personnel in avoiding the medication errors, for in case of a prescriber, they have to use sound medical reconciliation techniques. They have to avoid verbal orders most of the time, except in case of emergencies. And in case verbal orders need to be given, they have to be very specifically, precisely given. The drugs need to be spelled out completely, and afterwards the order has to be written properly and documented. Abbreviations need to be avoided. Example, U for units sometimes is seen as 0 or maybe a 4. 0.1 decimal would be seen as 1. So there would be small errors in case of wrong abbreviations. Inform patients of all reasons for all medications. Work as a team with consultant pharmacists and nurses, and use special caution with high-risk medications. So in most of the centers, the high-risk medications are kept separately with a special red label that is marked, and with double checking of these medications is done with double signature of the one who has prescribed to avoid errors, and report errors and adverse drug reactions. The pharmacists do not play a major role in India as compared to US, where the whole drug is also dispensed by the pharmacist in the Western world. So the role would be monitor the medication safety literature. In conjunction with doctors and nurses, they would develop, implement, and follow a medication error avoidance plan. And in case of sound alike, look alike drugs, they would use Tolman lettering. Tolman lettering is like a mixed font lettering, where a few keywords would be in the capital and the others would be in the small lettering. Like morphine is written as hydromorphine, and preferably avoid abbreviations. And report errors and near misses to internal and external medication error reporting programs. And the last and the most important barrier would be the nurses. They have to foster a commitment to the patient rights, because you are the patient's advocate. They need to be prepared and confident in questioning medication orders, because sometimes they would feel reluctant to really question the order to the doctor, but they might be right most of the times. They have to participate in or lead to evaluations of the efficacy of the new safety systems and technology. And the most important is support a culture that values accurate reporting of medication errors. So this is our hospital medication chart review checklist. It's got 3 pages, which is assessing the doctors, pharmacists, and the nurse. There are 36 parameters. So 36 parameters would be in the denominator, and number of drugs would also be multiplied with that in the denominator. If there are 10 drugs in the prescription, the denominator would be 360. And the mistake or some error identified at each level would be marked as 1. And that is how the calculation will be done for medication chart error. And this is done usually at routine intervals in our hospital, and fixed number of prescriptions are identified and assessed. So now to strategies. If we go step by step, what the strategies to prevent errors would be: accurate patient information. So proper patient information needs to be gathered for the newborn, like we discussed: weight, gestational age, any other relevant medication history. Standardized protocols need to be implemented, and guidelines need to be there for medication dosing, administering, and monitoring in neonatal units. In certain high-risk drugs or like inotropes, proper standardized drug charts based on the weight bands can already be mentioned, so that would get easier and no unnecessary calculations would be required. double checking needs to be incorporated to verify medication errors and calculations, again, especially for high-risk medications. Proper training and education of all the healthcare professionals at regular intervals regarding the medication safety, including the drug pharmacology dose calculations, needs to be there. There has to be a good communication amongst the healthcare providers with clear documentation. Standardized abbreviations have to be defined according to and accordingly mentioned, and effective handover process needs to be done. The newer technology systems like CPOE, that is computerized physician order entry, needs to can be done. It is not much used in India yet, but with this system, there would be the drug would be fed into the computer with proper dosage and everything. And in case of any error, the computer will auto calculate and would mention. So this would preferably avoid errors. Barcode scanning. So barcode scanning can be done in patient tags or maybe patient files. So this would, based on the barcode scan, the pharmacist can directly identify what prescription has been mentioned. Electronic medication administration records, EMAR, can also be there. And the last is encourage a culture reporting and learning from medication errors. So to identify what weaknesses are there in the system and what all corrective measures can be implemented to prevent future errors. So here are a few studies that have been, there are multiple studies done in NICU regarding medication errors, but this one is a systemic review and meta-analysis that was done, where 20 studies were done, and these included from various countries over the world. And all these studies were published from 2010 onwards, and majority of the studies were single-centric studies, and out of which 18 were done in the teaching hospital. So based on the evaluation of all these studies, the main 3 common types of medication errors that were found was wrong administration technique, wrong drug preparation, and wrong time errors. Another study, quality study done in India for improvement in the prescription was, this was done in Kolkata. It was a quality improvement study for 3 months. And this study, where the error, baseline error of prescription was 63%, was reduced to more than 10%. So this is like, these are the 4 PDSA cycles, plan, do, study, act cycles according to the point of care quality improvement model of WHO. So each cycle was a 6-week cycle, and initially there was 63% error, which decreased to 10.5 errors. This is another quality improvement study, again done for 4 cycles for 4 weeks, and they also found that there was an improvement in prescription from 65% to almost 100% compliance with the prescription. Another impact, this is just one study which studies on the implementation of CPOE system. This study was done in Taiwan and Tunisia, and they found that the errors decreased from 61% reduction. But this is not used commonly in India, and does not, and a few adult studies and systemic reviews suggest that this does not significantly reduce medication errors. So now the whole point of discussion is to ultimately reduce the errors. So the most important would be report the error, investigate, and try to get to the root cause, inform, and finally prevention. This very interesting report was mentioned in almost 1999, and it was published as a book in 2000. To Err is Human. So this emphasizes errors caused by faulty systems, processes, and conditions that lead people to make mistakes. This reviewed the current understanding on why these mistakes happen. They wanted to discuss that when people make mistakes, it is not the wrong intention or the bad people who are making the mistakes. It is the right people who are making mistakes because of the surroundings, or maybe the wrong surroundings. So that is why, if we summarize, discussing medication errors create a proactive approach towards patient safety, foster a culture of continuous improvement, and drives positive change within the healthcare systems. So basically, we would always try to comply to the rights of medication safety, right drug, right patient, right dose, right route, right time, and I would like to add right documentation. Thank you.
Thank you, Shraddha, for a eloquent presentation. It's a vast field, and a lot of, and it's actually rather probably a new field, because I think it's just about 25 years back when the IOM report was published and action was being taken. Just to start off with a few questions to Dr. Gautam, actually, if sir, is that correct that the IOM report was based on a single study and the extrapolations were wrong? Because in terms of there was some, this I read some time back on.
Well, the IOM report was based on a study done in the late 80s by Eric Thomas and colleagues. And from that, they extrapolated the number of 44,000 to 98,000 deaths per year in all age groups, not neonates. But subsequent studies have estimated that that number is actually an underestimate.
Okay.
And the real number of deaths is much higher because it does not include deaths due to nosocomial infections, which are considered preventable. And like Shraddha emphasized, that number is just the tip of the iceberg. So there's a lot more error going on in the system than is acknowledged.
Okay, yeah, great. So that was very helpful. Sir, another question is, I think you have done some work on reporting of medication errors in the NICU, and has reporting increased in the US? Because I think this topic for India is relatively new and not many people do it. But in the US, it's been there for almost 2-3 decades. So in terms of reporting errors, has there been a change in the US, or is it increasing, or what would it be?
The IOM report was published in 1999, and prior to that, there was, we have this joint commission which accredits hospitals, just like NBI in India. Is it called NBI?
NABH, so JCI, Joint
NABH. Yeah, NABH. Yeah. So they mandate a reporting system. And before 1999, everybody used to report things on paper and it used to be put in files. After the IOM report, all hospitals now have an electronic system to report errors, not just medication errors, but all types of errors. So if there is an overdose or a wrong patient receives a medication, or if a medication dose was missed, the nurse or the pharmacist will go into the computer and report that error. And they have to classify the severity of harm that Shraddha described. And they also describe the patient and the details. And ideally, organizations are supposed to study the patterns of errors over time to see if there's any root causes that can address. But in reality, what's happening now in the US is there are so many errors reported in the systems that these computers are filled with thousands of reports. And most hospitals don't have a good system of studying the reports and analyzing patterns. So we're sitting on a mountain of reports, which is not being tapped to yield information about system safety.
Thank you, sir. Dr. Kedar, you wanted to share some experience of yours, and if you have any things to say, because you are part of the quality review process in India, and you use your experience to teach a lot everyone about improving quality of care in India. So can you share experiences?
Thank you very much. I think I read somewhere the number of deaths occurring due to medication error in the US is like every other day one jumbo jet crashing. That is the amount of harm which medication error causes. That is the ultimate harm, but she has already described the severity of harm, from no harm to the ultimate harm of death. So we, as sir said, it is just a tip of iceberg. And Amy Edmondson did one study regarding high-performing organization. So in her book on fearless organization, she has reported this. When she tried to study these organizations, why some are high-performing, why not others, she had a presumption that probably the errors are occurring less in high-performing organizations. So when she studied, ultimately the conclusion was the high-performing organizations actually reported more errors compared to low-performing organizations. So that is the culture which is there in high-performing organizations. So we must build culture into our daily practices. Another thing what sir said is the root cause analysis of the errors which occur. That is a good thing to do, but the root cause analysis does not take into account the behavioral or adaptive part, problems associated with the errors. So that is one big area, and famously we say in quality improvement is 80% they are behavioral challenges and 20% are only technical challenges in any kind of improvement measure. So that behavioral challenges are sometimes overlooked with the root cause analysis part. So that also we must take into account. So I'm going to give one example here regarding a medication error which occurred in my NSU a few years back. So we had a baby with RH incompatibility referred to us from a nearby district, and we did double volume exchange transfusion for this baby. Next day early morning, I happened to visit NSU and I was reported that this baby's urine output is low and baby has tachycardia and baby was having signs of moderate dehydration. Baby also had bilious aspirates. So I told the fellow that this baby is quite dehydrated and we need to inject around 20 ml per kg of ringer lactate over next half an hour or 1 hour. So what she did was she told the nursing staff in charge. It was a shift change time in the 8 o'clock in the morning. And the shift was also for nurses, it was changing. So what she told another staff who took charge of that baby, the staff was a little junior, that you had to give, baby was 3.5 kg, so 70 ml ringer lactate to this child. Okay. And then after some time when the morning staff started pushing the ringer lactate, she had pushed almost 8 to 9 ml of ringer lactate. The other senior staff, generally we have a culture like in giving any injectables, two staff will come together, one will inject, another will they will just revise with each other what we are giving, how we are giving, what is the dose and all, and they will confirm the medication. So that was not done by the junior staff. So the another senior staff asked her what you are injecting. She said, I am injecting ringer lactate. But then she asked, but there is no bottle of ringer lactate in your warmer. There is no bottle of ringer lactate. So can you please show me what you are injecting? When she showed, it was a vial of concentrated ringer lactate, which is 25 times concentrated compared to the normal ringer lactate. She had already injected 8 to 9 ml. She had already injected 8 to 9 ml and she stopped her. And this was reported to the duty doctor and to ultimately to me when I went to their to my OPDs. So the junior staff which was injecting this drug, she came to my OPD and she started crying. So this has happened like that. Usual reaction will be to scold or remove the staff. So instead of doing that, we decided to use human factors approach, the crisis risk management principles which are used in aviation industry, which we are training in simulation, emergency simulation team training. So when we use those principles and try to identify the root causes, the process causes, what conclusion was that the first error was mine, that I gave oral order without reciprocating. So without confirming from the resident whether she has heard me correctly. Second was the resident doctor. So she told the staff without documenting we have a paperless NSU. So without documenting in our app, she just told her to give. Then the senior staff which gave handover to a junior staff without confirming whether she understands the difference between ringer lactate and concentrated ringer lactate. And The most important error was, probably we identified, was the bottle of ringalactate and the vial of concentrated ringalactate was lying in the same drug trolley. And CRL being the red alert drug, high alert drug, shouldn't have been in the routine drug trolley. It should have been in the high alert or red alert drug trolley, which was there. So instead of blaming, what we did was we did a system changes. We accepted that this is our error. And we removed that CRL from the routine drug trolley to the red alert drug trolley. So by red alert means these injections, whenever you are using any drug from the red alert trolley, it is a system in our NICU is you have to ask another staff or resident duty doctor before injecting this. So this has created a step towards medication error reporting or any harms or any errors reporting. So that is called psychological safety. So we haven't, we did not scold the staff or discreated in a sense, but we try to analyze in a system-wise manner. So you need to have a system level changes because these are system issue and not individual issue. Of course, ultimately somebody has to inject the drug and cause the error. That is there. But we need to analyze our processes and find out the root cause as well as you need to provide the psychological safety to your staff so that there is a culture which is developed, which it cannot happen overnight. It is going to take a long time. So that is what I wanted to share. There are other things also I will share later on.
Yeah, I think thank you, Kedar, for it. And Dr. Gautam, if you want to say something about this particular incident, and also I think you can begin to share your slides right now. Till that time, I would suggest other participants to please share your questions in the chat, which I can go ahead and ask. Thank you. Sir, please go ahead.
Can you see my slides?
Yes, sir, we can see them.
Yeah, thank you, Kedar, for emphasizing the systems approach. And Shraddha, I want to congratulate you on an excellent presentation. I was very impressed. A great job.
Thank you, sir.
And when you analyze what is the underlying set of causes for errors, whether it's medication errors or any other errors, people often say the first tendency is to blame people. So we say, who was responsible? So 20 years ago, I said we need to change that question, who was responsible, to who is responsible. But the who in this case is an acronym that stands for work conditions, human conditions, and organizational conditions. So instead of blaming individuals, you should look at work conditions, human conditions, and organizational conditions. So work conditions, as Shraddha described already, work schedules, equipment and workplace design, decision support, human conditions, training, fatigue management, stress management, communication. I don't know if that Ringer's lactate incident was the resident post-call or sleep deprived or fatigued or stressed, we don't know. And then organization conditions. We've already talked about the need for psychological safety, team training, systems for reporting, allocation of resources to safety, including staffing. Right now, I'm working as the head of the Department of Pediatrics. And at a high level in the organization, we constantly have to make decisions about hiring more nurses and doctors, which will improve safety. But then we may not have money for other programs. Even in the US, it is not an endless supply of resources. So organizations have to make trade-offs, and how they make trade-offs, how they value safety is very, very important. I'll give you an example. We have a shortage of hem-onc pharmacists. So chemotherapy is one of the highest risk drugs that we use in pediatrics. So typically our pharmacists oversee the safety of chemotherapy, the preparation, they double check the orders, they oversee the administration. But we have a shortage of a pharmacist because one left and the next one is, the replacement is starting on October 1st. So I had to advocate and said that our hematology oncology doctors now have to oversee chemotherapy for 2 hours each day, which means they will not be seeing patients and we will lose revenue from patient billings for 2 hours every day. That's a lot of money. But I pushed for it so that we have chemotherapy safety, because I don't want to be responsible for a severe chemotherapy error in an oncology patient, which is bad for the patient, the family, and the organizational reputation. So that's the kind of trade-off that is in the O section. Now, I know there are a lot of participants in the session. I want to first show this Swiss cheese model, which is dynamic. So if you put the WHO model, and what we do is to promote safety, we add layers of Swiss cheese, for example, double checks. We have special worksheets to calculate the medications. We have rules about how to order, like tall man lettering. But each of those safety mechanisms is imperfect. And what you want is for the error to be caught by one of the intact layers of the Swiss cheese. Swiss cheese model illustrates that the error propagates through all the defenses when the holes line up. So that's an important phrase. If every error causes harm, if the holes line up. Otherwise, if somebody writes the wrong order and you have a double check mechanism, the intact layer of the Swiss cheese, which is a double check, should catch the wrong error. But if the people are distracted or tired and they don't catch the wrong order, then the error propagates through the system. So that's an important clarification about Swiss cheese. Now, I want to ask the audience, anybody can answer. This is a nurse programming an infusion pump to give a medication to a patient. What do you notice about the design of the infusion pumps that will promote safety or increase the risk of medication errors? Just share your observations with me.
Participants can please share. You can unmute yourself and talk.
Right. And if anybody chats, please read the chat to me. I'm not able to watch the chat.
I'll do that. Unfortunately, my internet got disconnected twice. Yeah, screen is horizontal is what Dr. Preeti Jain has said. And Ms. James has said from vertical alignment, horizontal alignment of syringe pump should be maintained in the chat.
So why is the horizontal important? Preeti?
That's James. She said horizontal alignment should be there. And Dr. Prashant Karya said 2 and 0.2.
Yeah, I can read the chat now actually. So
okay.
So why is vertical versus horizontal important, Ms. James? Because vertical is easier to read.
For accurate reading, an accurate readiness to read and administer.
Yeah, I can read the chat now. So what else do you notice about the screens? Which screen is easier to read? The top screen with the horizontal infusion pump or the bottom screen?
The bottom screen.
Why is it easier to read?
It's like a direct visual. It's like you don't have to convert the image. It's just directly what you're seeing. You're going to implement.
Okay, so the text is more explicit. What else makes it easier to read? Yes, Jubilant is right. Horizontal means you have to twist your necks to read. Humans stand vertically, they don't operate horizontally. So the display should be aligned with our human anatomy. Okay, Shraddha, you're saying the lower screen is easier to read because of what?
Contrast.
Look at the contrast between the white text with blue background gives you contrast, right? Whereas the top screen, there is more glare here, isn't it? That makes it hard to see. Plus, intrinsically, there's not much contrast between the font and the background.
Right.
Then if the nurse is programming, which infusion pump is easier to program? If she's entering the infusion rate, which one is easier?
The lower one. The keys are also more clear and better in the lower infusion pump. The numbers are also easy to set the dosage.
Yes. Yeah. So this is an example of human factors design. The lower pump will enable humans to perform accurately better than the upper pump. And you see this kind of design in your car dashboards and other equipment, your toaster or your coffee maker. So people who design equipment should pay attention to all these details. And yeah, Ms. Jubilant and Preeti are making some important comments about display and what medications should be displayed. Let's look at another example. This is a blood sample vial, which is getting labels wrapped around them. What do you notice about the labels that either promotes safety or increases the risk of errors?
So proper name is not mentioned in the green sticker. It is mainly baby boy, maybe. Oh, I think it has been.
So this is not strictly medication error, it's more of a lab testing error. But if you use labels like this, which are hard to read, on top of that, they're wrapped around the specimen tube, it makes it very hard to read. And you can see that at the bottom, it's twin B, right? So if you have twins and twin A and twin B both get a blood test, the design of the labels will make it easy for one twin's blood sample to be mixed up with the other ones. It's in the lab when it's reported. So again, human factors, design of display and labels. Okay, look at this one. What do you notice about this?
Look-alike.
Yeah, so this is an example of look-alike drugs. There are also sound-alike drugs.
Right.
Where the names sound similar.
Same.
What is LASA, Miss Jubilant? I don't know.
Look alike and sound alike.
Look-alike and
Oh, I
sound
see.
alike.
Got it. Yeah. I thought you were taking me to Tibet.
No. So this is actually NABH uses this terminology while training. LASA.
Got it.
That's from there.
What do you notice here? These are all actual pictures from a US hospital.
KCL is a high risk which has been kept with dextrose, so it looks the same with normal.
Yeah. So dextrose, sodium chloride, and potassium chloride are all put in the same bin.
Same bin.
Yeah, if you put it in the same bin, one of these days somebody will make a mistake. Okay, so don't blame individuals for making mistakes. If you put stuff in the same bin, it's like in your kitchen. If I put different ingredients in the same cupboard, one of these days you will put salt in my dish instead of putting sugar, right?
In my tea.
In my tea, yeah, exactly, yeah. So again, this illustrates the importance of labeling, storage, and use of human factors in making it easy for humans to do the right thing. So there is a quotation in safety, right? If you make it the easiest thing to do the right thing, then people will always do the easiest thing, which will be the right thing. If you make it hard and they have to develop workarounds, then it will create errors. There was an example in Indiana many years ago where 6 premature babies got overdosed with heparin. And it turns out there are 2 concentrations of heparin. In one vial, you get 10 units per ml. In another vial, it's 10,000 units per ml.
Yes.
So in this hospital, the pharmacy technician who brought the heparin vials to the unit accidentally brought 10,000 units per ml vials kept them in the unit, and the nurses thought that was the standard 10 units per ml heparin, and they used it to like mix the heparin in the IV fluids. 6 babies got a high overdose of heparin. 3 of them died from it, and I think 1 or 2 developed an intracranial hemorrhage from the heparin. And this is the CEO of the hospital standing in front of the press, explaining what happened and how the vials were mixed up with each other. So if you are the head of a hospital like Kedar, you don't want to be in front of the media trying to explain what happened in your hospital. So this illustrates that, no, this is not Denzel Washington, sorry. Maybe one day they'll make a movie about it and Denzel can star in it. But this illustrates the high organizational risks of errors. What do you notice here? So once in a way, in anesthesiology, this used to happen in the past.
It's like the electrical wires in India, all meshed with each other.
Yeah. So it was common in the past, if the anesthesiologist wanted to give oxygen to a patient after surgery during recovery, they would accidentally plug the oxygen tubing into the nitrous oxide outlet. So what the anesthesia specialty did was, they said we can tell people to be careful all we want, but they will still make mistakes. So let's redesign the system. So they changed the color of the oxygen tubing to a green and the nitrous oxide to blue, and every tube has a different color. Not only that, they changed the design of the nozzle so that the oxygen tubing will not fit into the nitrous oxide outlet. So that's a human factor solution to eliminating errors. Now, can this happen in your car if you're going to fill in petrol? Can you accidentally fill in diesel?
It happens.
It happens, right?
Yes.
So that's a human factors problem with the design of the gasoline pumps. So same thing with anesthesia machines, sevoflurane and isoflurane. Sevoflurane is yellow, isoflurane is purple, and the sevoflurane outlet is rectangular, isoflurane is circular. So even if I want to, if I'm sleep deprived, I cannot plug in the wrong thing into the isoflurane outlet. So those are some examples of human factors, not blaming.
System level changes that is also
share. I think many of this prevention is usually, I think there is a 70-20-10 rule. 70% can be prevented by design for various things, 20% by kind of administrative changes or rules, or like making sure that people are slept properly or whatever, or have enough break, and only 10% is usually by education or insisting that people follow something. That would be right, correct?
Absolutely, yeah, absolutely, yeah. So let me finish up my slides and then we can have an open discussion. So what do you see here? What is in the syringes?
Intralipids or feeds.
Yeah, one has intralipid, one has milk. And in the US, it is once in a way, there is some baby in some unit who receives intravenous milk by mistake. Because the nurses cannot tell the difference. They'll both look white. So what we use in our unit is this system for feeds. So for feeds, we use a tubing that comes out from the syringe, because in our unit and most NICUs, milk is administered with an infusion pump, not by drip. So the tubing for the milk has that orange tip and it can only fit into the NG tube. It cannot fit into an IV because of the size and the design. So the color and the design signals you that, okay, you're accidentally connecting it to the IV. So there's another example of human factors. Now, I just want to talk a little bit about what is known as the second victim. This is a photograph of a nurse in Seattle Children's Hospital. She was a PICU nurse with a lot of experience. And one day, she accidentally was involved in an error where a child got overdosed with intravenous calcium, and that child died. So she was so traumatized by the experience that she committed suicide. Because the investigation was done, they did a root cause analysis, and she committed suicide. So this is known as the, does anybody know what this phenomenon is called? Any of the trainees? Say that again. So this is known as the second victim phenomenon. Who is the first victim? The patient and the family. The second victim is the nurse or the doctor who was involved in the error. And it can be very traumatic and devastating to us to be involved in an error. Okay, so there's a question from Dr. Trivedi about what is the moral guideline for informing the guardians? Let me ask people, do we still have time or?
Yes, we have.
We have, sir.
Okay, so what would you respond to Dr. Trivedi about what's the moral guideline for informing the family, and what should we do? He's giving an example of bolus KCl mistakenly pushed, causing an arrest, but luckily the child is revived. Why should we tell the family? We can just keep it quiet. They'll never find out, right? I'm being provocative.
So I don't know if anyone else.
Ideally, this is to be disclosed to the parents in black and white, in front of the social workers and the team members of the unit. There is a committee for this kind of thing, and the unit will sit and discuss it out. But truth need to be in black and white, conveyed to the parents with apologies and all those things.
Yeah, agreed. So the recommendations in the US are to be completely transparent in your disclosure to the extent that you know. Okay, so you should not be very hasty to disclose. You have to finish your investigation first before you disclose, because sometimes I have been in situations where people go in and admit guilt and blame themselves, and later on you investigate, you find out that there was no error. So complete the investigation, be sure of the facts, be sure of what you don't know, then you disclose to the family in an honest way. But the problem with following this in India, and I've always wanted to do a study in India, is the family attenders get violent. And there are many instances where doctors have been beaten up, hospitals have been burnt down. So it's not a straightforward thing. And I don't know what the solution is, but even in the US, we are dealing a lot with what is known as workplace violence, where patients are getting angry, abusive, sometimes physically attacking the doctors and nurses. And sometimes in these disclosure conversations, we have to have security present. So we'll just have them standing outside the room or just be visible so that they don't get angry. Any other thoughts about disclosure? What do people think?
I think NABH requires you to disclose it, if I'm not wrong, that it is required to disclose. There's a process, or you have to have a protocol to follow if there is a medication error. NABH also requires us to have what is called as a critical incident reporting. So not only medication, something goes wrong, to ensure that there is a reporting that is done and systems are improved. So there is like in our hospital, we have followed processes, and actually it has helped quite a few times to ensure things improve and it is not left to people. Sir, I had another question. I think in 2008, 2009, Obama in the US started this computerization of medical records so that errors are reduced. while doing this review of these articles, we found that there is not much evidence to suggest that computerized process of order entry has reduced medication errors significantly. There is some evidence, but not, and generally when that evidence is that it is in conjunction with other practices and not only so computerized entry. So what are your thoughts on that?
Yeah, the evidence for CPOE reducing medication errors is not very high level, but it was introduced more based on just belief that it would change and over time it would get better. And when CPOE was introduced, there were, I think, 8 or 9 new types of errors that the experts pointed out that electronic ordering systems can introduce. For example, if I'm going in to order, say, dopamine or a high-risk medication on a twin, I go into the computer, twin A and twin B are in alphabetical order right next to each other. So I can easily pick twin B instead of twin A and order the medication in the wrong patient. That would have been harder to do in the paper system. And decimal point errors or tenfold errors sometimes can be magnified with electronic systems. But in general, I think over time, we are seeing fewer medication errors from CPOE than with paper charts. A couple of other things I want to mention before I forget. One of the best ways to avoid medication errors is not to use medications. I think there are a lot of medications that we use that are not evidence-based, unnecessary. We just use it because we feel we need to do something. So the fewer medications you use, the better.
That's a behavioral challenge then.
Sorry?
That's a behavioral challenge, not a technical one.
Yeah, exactly. Then a lot of medication errors occur at home. So if you're discharging a baby on some medications, it's really important to educate the family and make them demonstrate that they know how to measure the medication and administer it so that you don't have medication errors at home. Because we've had babies get readmitted with Tylenol overdose and a lot of other things that occurred at home. And then I think for your units in India, it would be good to come up with a simple list of interventions that can promote safety, like the use of worksheets, use of readback protocols, use of verification and double checks. Many of you may already have these. So short of electronic order systems, you can have all these other systems that can promote safety. So let me stop talking now and see if there's any questions. If there's time before we wrap up, I have a brief story about disclosure, but let's hear from others. Yes, 10 medication rights now, yeah.
So again, I think that's NABH, medication rights. This is part of NABH. So what happens is, sir, from the National Neonatology Forum, we do what are called as accreditations across India for various NICUs. What we have found is those hospitals which are NABH accredited usually have a very high level of quality control, and they definitely do much better. So over them, even like maybe say 5-6 years, things have improved quite a bit in terms of ensuring things get done correctly. Others, if anyone else wants to ask a question or say something, this would be a good time to do it because.
Yeah. So, sir, I have a few things to say. So, what sir said rightly, that what we do here in our NICU to prevent medication error is at the beginning of each shift. So, every staff presents in short what are the medication timings, how they are going to prepare them, and how they are going to administer them. So, using those hours, so we have identified 8 hours. From 5 hours, we have shifted to 8 hours. Right, from the right patient, right time, right drug, right dilution, right dose, right route, right duration, and right documentation. So that way they will discuss it at the start of the shift with the resident doctors. So that resident doctor is also aware of any changes which are done, and you can confirm it from our tabs from the app. And if there are any discrepancies, then they discuss it out and correct it at the beginning of shift itself. And another thing which we have included is huddles. So in the morning, we carry out team huddles with all stakeholders. And there we discuss some of the medications which are not routinely used. For example, like digoxin or furosemide, which is not used for every now and then. So those medicines or those equipments which are we are going to use, which are not used previously. So then we discuss about them in short, so that the errors are prevented. Like if you are giving Dexa for CLD, so what dose? So every third, fourth day we are going to change the dose. So how you are calculating, how you are going to take this dose. So all these things we have added to our daily team huddles in the morning. So these are the two interventions which have helped us to reduce the medications error. We are also documenting on a visual management board all QI indicators, including medication error, the last date. And there is a data. As far as sir said, discharge process medication error. So we have undertaken a quality improvement initiative to optimize discharge process, wherein like post-discharge screening, medication error, and all those things we have taken into account. And what we have found that we have reduced medication error from about 10% to less than 2%. So by optimizing the discharge process. So, and we are also, prescriptions are there in the language which the patient understands, other than in addition to the English language. And then once it is handed over, patient is counseled, mother or whoever caretaker is counseled. At the time of discharge also, we are cross-checking it with questionnaire, which includes one of these regarding screening, regarding medications, what you are going to give, regarding follow-ups and all those things. So it has helped a lot to reduce those errors.
Yeah. So I just want to share a thing of disclosure. Actually, myself and Dr. Dipen have published this paper, I think 2012 or 2013. This was a patient who was supposed to get OPD level amoxicillin, and by mistake he got amlodipine in the pharmacy. This was when I think paper records were there, and the patient took amlodipine for quite some time, 4 days or 5 days, and then came in severe shock. Patient survived and went home, but that was one serious. So in my own practice, actually, I probably have had at least 5 to 6 medication errors that have happened in patients that I've been treating. So it's not a really uncommon thing to happen. So from my side, that was, and we told the patient that, and amoxicillin and amlodipine are similar names, and the pharmacist did not realize, and that patient did well finally, luckily, but it was quite a challenging thing to treat also, amlodipine. So it would be amlodipine poisoning, definitely. Sir, thank you. You can go ahead with your disclosure.
Yeah. So about 20 years back, I was involved in an error where patient was exposed to a severe error, but luckily after a few days got better. And soon after the error occurred, I went and disclosed it to the family. And it was a very hard conversation because I had to explain that we, the healthcare system, had inadvertently exposed their baby to harm. And at that point, before I went into the family, I asked a colleague of mine and asked him to be on standby. When I spoke to the family, the parents, I said, I can understand if you lose trust in me as a doctor. If you want a different doctor to take care of your baby from this point on, I can arrange that. I have a colleague ready to substitute for me. They thought for some time and they said, no, we want you to continue. Then after the baby improved and was being discharged, I sat down with the family and went over in detail how exactly the error had occurred. It was a systems issue with human factors, lighting, and a lot of patient volume, workload, and so on. So, and I had some equipment to illustrate how exactly things went wrong. So I went over everything, and they thanked me for explaining what had happened in detail. And then the father said, Doctor, do you remember how you asked if you wanted to be removed from the case? I said, yeah, I wanted to offer that in case you did not trust me anymore. He said, you know, I am an engineer and we do root cause analysis and human factors analysis all the time. So we knew it was not from your negligence or you being careless. And we knew that there were a lot of people under you that were involved and you were just a responsible person on top. Then my wife and I talked. We said this was an inadvertent error. It was not due to carelessness or lack of knowledge. And from now on, of all the doctors in the hospital, this doctor will be the most careful in caring for our baby. So we said we should have him and not anybody else take care of our baby because he'll be ultra careful going forward. So we felt actually safer with you going forward. And that was it was a blessing for me to hear the trust in me had continued even after their baby was potentially exposed to harm. That incident still stays in my memory even after 22 years. So that was my personal story of disclosure.
Thank you very much, sir. It has been a very nice session today. We hope that we are able to get you for some of our ventilation workshops in the future in India at some point of time. It would be a pleasure to have you. And for people who don't know, sir has often come on Neonatal Pathshala and the IIP, Gujarat IIP Pathshala also, and also does sessions in Karnataka where he teaches MBBS students research. So sir has been very kind and has been extremely resourceful, and we had the opportunity to meet him at PAS this year in May. And thank you, sir. Thank you very much. And I hand over to Dr. Dipen Patel.
Yeah, thanks for inviting me.
Thanks a lot, sir. Dr. Dipen will do the honors.
Thank you very much, sir. Dr. Gautam sir and Dr. Kedar and Dr. Somsekhar Nimbalkar. It was really exciting discussion with your all experiences, our audience, as I think they have become more aware of where they can make mistakes. I am sincerely thankful to our Pathshala platform, that is ClearNet, who have provided this unique platform since last 1.5 years. They are continuously supporting us. Thank you very much, Dr. Shraddha Patel, for nicely presenting this seminar. I thank all the delegates also who have participated, and NNF Gujarat also wishes all the best to everyone. Thank you for the session.
Do we have certificates?
So
we don't have.
Yes, sir.
We have
Yes,
the
sir.
certificates.
Yes, sir. Yes.
Yeah, sir. We are going to be sharing certificates for everyone. Rituparna.
So on behalf of NNF Gujarat, we are lucky to have sir as an expert. We are thankful to Dr. Shraddha Patel for being a presenter in Neonatal Pathshala in PG seminar, medication errors in newborn on 12th of July. We are also thankful to next certificate, please, Rituparna. Yeah. We are very much thankful to our sir, Dr. K. Suresh Gautam sir, for being an expert and sharing a wonderful experience of his with us in the early mornings. So that was really wonderful for us. And we are really thankful to Kedar Salvatkar, as well as our own Dr. Somsekhar Nimbalkar, for being the experts in the same session. So thank you, everyone. We'll be meeting on same link, Neonatal Pathshala, every Wednesday at 3:30 to 4:30. So thank you. And it was really a wonderful presentation as well as a discussion. So thank you so much once again.
Thanks a lot. Bye. Bye, everyone.
Bye-bye.
Thank you.
Bye,
Thank you, doctors, for sharing such valuable insights. I hope you had a seamless experience and looking forward to host you again very soon. So with all your due permission, dear doctors, we are signing off for today. Until then, stay safe and healthy, everyone. Have a nice day. Thank you.